No, just tomorrow morning.
Yeah, there's only 30 people right now, and there's more coming in. So.
Okay.
I've spoken with them.
Okay, good morning, everyone. Those online and those in the room, good to see people in person. We want to encourage people to come to our rounds when we do have this hybrid. We have our speaker who is willing and able to come here in person. We do have coffee for those people who are here. So welcome, everyone. And in terms of announcement, well, if anyone has any announcements, please feel free to let me know or to speak up. In terms of our, and today is a co-sponsorship of this rounds with the HIV Center with our LGBTQ+ program in our Division of Gender, Sexuality, and Health. And so welcome to those folks who are joining us who may not always come to HIV Center rounds. Our next HIV Center rounds is on February 15th, and it's Dr. Sanisha Dale from University of Miami. I don't have a title for her talk yet, but Sanisha conducts research on the intersection of mental and physical health, and specifically HIV and things like trauma and mood disorders, and also developing interventions for that population with a strong emphasis on engaging community members and stakeholders in research. So I think broadly she will be talking about something within those domains. Following Dr. Dale, our next rounds on March 7th is Dr. Natalie Crawford. And the working title of her talk is right now, Structural Approaches to Reducing Racial Inequities in HIV. Any other announcements? LGBTQ+ program or HIV Center or anything? Okay. So let me introduce today's speaker, and thank you so much for coming here in person, Dr. Jeffrey Birnbaum, who is an adolescent medicine specialist and board-certified pediatrician. He's also an assistant professor of pediatrics at SUNY Downstate Medical Center. He's the principal investigator and executive director of Health and Education Alternatives for Teens, known as HEAT. At HEAT, he has provided medical care to hundreds of HIV-infected youths ages 13 to 24. Since 1992. In addition to his clinical work at HEAT, he devotes much of his time in community mobilization efforts to identify and engage HIV-positive youth in care and HIV risk uninfected youth into PrEP services. He has served as a board member of the SUNY Downstate Medical Center, HIV Center for Women and Children Institutional Review Board, and he has served as a liaison to the New York State Department of Health AIDS Institute Pediatric Adolescent Ambulatory Care Guidelines Committee, which sets standards for HIV testing and medical care for HIV-infected children and adolescents in New York State. So, I mean, as you can see, and I can go on and on, I'll just say a little bit more. And we were talking earlier of how we, a few of us have been in this work and in this field since the early days of the epidemic, and the passion and the need for working with these communities and continuing that is so profound. And Dr. Birnbaum is certainly one of those people that was a pioneer in this field and is still doing really important work. In fact, he has pioneered efforts in Brooklyn to engage young gay, bisexual male youth and transgender youth from communities of color in medical care, prevention activities, and HIV counseling and testing efforts. I'm going to end with, there's a lot more than what I'm going to say, but there are some important recognitions and awards that Dr. Birnbaum has received. With HEAT, he has been recognized with several prominent awards, including an award from the New York City Mayor Michael Bloomberg in recognition of HEAT's outstanding work with HIV-positive adolescents in New York City, and the very prestigious Linda Laubenstein Award for Excellence in HIV Care by the New York State Department of Health AIDS Institute. I remember being there in Albany when you received that award, and it is a very prestigious award. He's also been awarded the SUNY Chancellor's Award for Excellence in Professional Service. So thank you. He's here today to talk with us about a novel approach to combining transgender affirming and HIV care in a youth-focused clinic. Welcome, Dr. Birnbaum.
Thank you, Rod. Good morning to everybody in the room. Good morning to everybody out there on Zoom. Thrilled that everybody is here. There's a lot to unpack in that title. Hopefully, over the next hour or so, I can unpack that for you, and we'll have plenty of time for questions, and we'll jump right into it. Here are our learning objectives. I'm going to give you a second to look at that and then keep moving. Any talk having to do with transgender health always has a slide that looks like this. They always have the gingerbread person. I have another version of this slide that's literally gingerbread, just to separate out differences between what a person's gender identity is, their biological sex, or as we say these days, assigned male at birth, assigned female at birth, and so on. Separating out their sexual orientation from that. Folks from my generation sometimes conflate the two. We may have been the AIDS cultural warriors, as Bob was referring to, but still our generation tends to conflate those two. People need to understand the difference between someone's sexual identity and their gender identity. While there's plenty of overlap and they relate to each other, they're not the same thing. And then, of course, how somebody presents to the world is their gender expression. I'm not going to go into that much more. I think I'm talking to a well-informed crowd here. Just to say that things are very different these days in 2024, in that I talk to medical students, they say, why are you telling us this? This is a generation where in high school or in middle school, they had to state their pronouns. To me, when I have to state my he, him pronouns, sometimes I say it feels a little weird. Like I never had to do that when I was growing up, but for younger folks, it's natural. And so I think it's just important to talk about changes in society, and as bad as it is in many places in this country for transgender folks, the world is very different, and there are places like New York, which I refer to it as a safety bubble, where these things are completely normative expressions. So jumping ahead, so going into some of the health disparities, people who are transgender or non-conforming have trouble with healthcare system, plain and simple. I'll give some examples and some information and data about that. When people come into healthcare systems, they're often turned away. They're told by well-meaning providers who otherwise would not turn someone away, say, well, I don't know how to treat syphilis in a transgender person. What does that mean? You don't know how to treat syphilis. It's called bicillin. You just give an injection. And that leads to larger health disparities. I'll give another example. A transgender man having dysfunctional uterine bleeding. They'll go into an emergency room. It's a bleeding uterus. That's all it is. I mean, there's a person behind that bleeding uterus, but treat the clinical problem. Don't say, we don't know how to treat you. That leads to people avoiding care, worsening health outcomes, and so on. And you'll see, morbidity, mortality in excess of what they should be because of really what is just societal attitudes that people just haven't wrapped their head around. There's not a lot to wrap your head around, really. There's actually some more data which I need to at some point include on this slide, but LGBT competency training is catching up compared to some of the information that you see on this slide. I know at Downstate, it seems like some weeks I'll be speaking to the Department of Medicine. I'll be speaking to first-year medical students. I'll be speaking to pediatric residents just on this topic of transgender health alone. Medical schools and academic departments, residencies are getting a lot better than the data on here represent. But this is something that is a work in progress, and that for us to change the healthcare environment, we need to continue to do better at LGBT competency training. So I'm glad there's LGBT health fellows in the room here. There's discrimination against transgender people. Looking at the United States Transgender Health Survey, people reporting all kinds of harassment, physical attacks in school. The data on the left is from 2016. People leaving school because of the way they were treated. On the right, we have some data about harassment in the workplace, people not being given jobs because of their gender identity or expression. And then all this verbal harassment, physical attack, sexual assault. These are real things that individuals experience out in the street. And when you work in a clinic that serves transgender people and people walk in the door and they're like wired and on fire by the time they walk in, and you say you're 5 minutes late and they blow up on you. This is why they blow up. This is what they've experienced out there in society. And you really have to think about that when people are on edge, when they present to you, and do things to kind of put them at ease with you and let them know that they've entered into a safe space, or at least a safer space. In healthcare, just looking at some of these stats that were in the same survey, third of people talking about a negative experience related to being transgender, that got harassed in a healthcare setting or denied care. About a quarter of them just avoid care entirely, just to avoid that type of horrific experience. And then, of course, poverty, people not having financial resources or insurance to be able to just get to the doctor. So let me shift gears a little bit and talk about HIV and transgender persons in New York City. Looking at trends over the years, we've had all these End the Epidemic campaigns at national, state, and local level here in New York City. And you can see that while the top curve for men, that would be cisgendered men, while we're really doing great things to bring numbers of HIV infection down. You can see what happened in 2020 when the world fell apart due to COVID. Things started to go back up again. The numbers for transgender individuals are relatively low overall. However, the risk, I would say, is that much higher because of all the things that I just mentioned on the previous slide: access to care, just general care being a big issue, and it's very labor intensive. And these are numbers of people that are reported as newly infected per year. What's interesting is that the health department changed the way that they report this information. So if you look for, try to get an updated slide, they go right to, instead of new diagnoses, they don't produce that. In the most recent slide set, it's how many people who were newly diagnosed were connected to care within 90 days. And so that's kind of interesting, but not the subject of today's talk. Okay, looking at through this 5-year period, who was identified with HIV. You look at the tall red bar, you see it's transgender women who are ages 20 to 29. That's the age group that I serve. And actually, although in my introduction, you cited something I wrote, it's 13 to 24, we've actually increased our age group up to age 29. And especially for transgender individuals, we're a little, I'll use the word fluid with our age cutoff, because it's hard to find good places for people to go for care, especially if you're sending them to a different borough and they're traveling far to come to you, and you don't know what's good near their home. So transgender women are the ones at highest risk. Looking at those transgender women, they're Black and Latinx. And so we're looking at transgender women from communities of color. So how did I get into doing transgender care? Like a lot of folks that work in the transgender field, I'm one of those who got into it through doing HIV work. And early on, when I had my first transgender patient come in who was HIV positive and transitioning at that time, she said, "Can I get my hormones from you?" There were no real guidelines back then when I was doing it. I just looked for anecdotal information and I said, sure. Made it up as I went along. A lot of the stuff that I'll cite certain behavioral theories. I cite syndemic theory here in this slide, but that comes after the fact. Oh, that's what I was doing. Oh, okay. Medical care, HIV, transgender health, homelessness, violence, substance use, you just layer it all on top. But you know, when you open your door to one transgender person and then she says, can I bring my friend here too to get her hormones? And my first question at that point, we were just an HIV clinic. I say, is she HIV positive? And she says, no. And I'm thinking, I said, bring her, because if I say no, you can't bring her because she's not HIV positive. I'm basically outing her about her HIV status, why she can get it and her friend can't. So, so it's just like the floodgates opened, and there were a lot of transgender women coming in back then. And a couple of years later, the guys started coming as well. I cited syndemic theory. I'll give some information how we got into that, but treat everything all at once. Don't treat this as a medical condition or, you know, mental health folks, gender dysphoria, mental health diagnosis. Treat it as everything all at once, and have case managers, mental health, medical folks, all on site in one place. Make it easy for people to get everything addressed kind of all at once. Obviously, you got to dissect it out. And the levels of stigma are so great that provide your care in an HIV status neutral environment if you're going to be providing HIV care. Obviously, you got to have culturally competent staff. We use WPATH and Endocrine Society guidelines, and work with agencies, in particular youth agencies from my clinic, that are serving transgender youth out in the community, because they're going to refer people to you. They're desperate to find good places to send people. And that a lot of my approach, well, things are a little different today. Things developed by dealing with folks that have had incarceration. We're doing sex work, homelessness, you know, borrowing hormones, silicone injections in the back of beauty salons, and so on. You see less of that today because since 2017, it's been available in New York City. I think 2017 through Medicaid. So there's a lot less underground trade of hormones and transgender treatments, but that's still in my head. Those factors that drove people to do that are still there. So in 2012, and I apologize for the lack of a closed parentheses, it's really bothering me at the end of the first bullet. We were doing this care for a long time, and we didn't have a label for it, but we saw this funding announcement for a SPINS project to engage HIV positive transgender women of color in high quality HIV care. And so we said, all right, we need a behavioral theory to put into this application. I said, oh, this stuff looks really good. Syndemic theory layers all the problems on top of everything. And then, and so on, you know, you can see the work of Singer, you can see the work of Brennan, and we put in a lot of fancy language, but really just like address people's lives. That's all that it really says in a very fancy way. So I felt very strongly back then, I could see the stigma for HIV positive women, that you need to do things in a status neutral way. And I had an endless argument going on with folks I had to answer to in this project, because it's Ryan White money. You can only serve HIV positive people. No, you're doing this the wrong way. It's just about HIV. And I said, no, it's not. And it created a lot of stress, had an impact on our ability to function through the program. But I stuck to my guns on this and pooled other non-HRSA, non-Ryan White funding in with this so that we could provide an HIV status neutral environment. And basically what we were looking to do was work with the Hetrick Martin Institute to engage people, the largest LGBT youth agency in the city, so we could meet them out there and somehow get them across the river to our clinic. Providing the multidisciplinary care in the model that I said, do everything at once. That's how you apply syndemic theory ideas to your clinical care. And then they just said, we need to have an intervention. You need to have a group intervention. You need to have a group intervention. So we came up with one called Just One of the Girls. And boy, did they fight with me when I said, We don't want people to disclose their HIV status in this group, and we want it to be status neutral. They gave me no end of grief about that, but I stuck to my guns. But a lot of people just didn't want to come. They don't want to come to a group. The stigma is so great, even in the HIV status neutral setting, that it's a little scary. So we kind of developed just one of the girls based on some principles that are in other interventions that are out there that have been validated, SISTA and Willow. SISTA is for HIV prevention in African American women, and Willow is for women who are already HIV positive, prove their health outcomes. We just kind of mashed it all up and put the transgender topics into that. And we tried to do a two full day weekend retreat. And while the clinic blossomed under this, running just one of the girls was a bit of a disaster and was not successful in terms of recruitment. But what did we get out of this? Again, this becomes what I recommend to other folks who are looking to do this type of care. We came up with a transgender protocol, which we still follow today, and have a transgender focused intake process. Ask people about all the different names they go by. I'll show you intake forms in a little bit. Make sure your case managers understand the needs of a transgender clientele with employment, their names, their identity cards, nothing matches. And we're also dealing with youth. So they change their names, bits of their identity frequently. So some of that stuff can be all over the place. And you just have to have case managers who understand that and are prepared to address those changes in identity and so on. Mental health services. Mental health needs are so unmet in this population, and not because they have gender dysphoria, but because they have PTSD from being beat the crap out of on the street and so on, being rejected by their families, throw HIV on top of it, and so on. And a lot of these folks, I see it less now, a lot of these folks have been maltreated by psychiatric systems. They've been labeled behavioral disorder, things like that when they're younger, and these labels stick to people. Have your HIV care and your gender affirming care located in the same place. If I'm seeing someone for a visit, I'm prescribing estradiol and Biktarvy. Not supposed to use brand names. Antiretroviral treatment at the same time. Have providers who can do that. Have culturally competent staff, and again, other support services. So just showing a couple of things how we've integrated that. We have preferred or chosen name, birth name, legal name. Give me all your names. And the ID check that's on here, like, what does your ID say? Scan them all in so you understand how people go by different names in different places. And as well, like, who's sending folks to you? Who are your friends out there who you need to build your relationships with, your referral sources? Again, straightening these things out at the beginning. What's their sex assigned at birth? How do they identify in terms of gender? What is their sexual orientation? Who are they attracted to? Which may not match who they're actually having sex with. And sometimes there's, I have other under identified gender, but there's a lot of other that goes on in a lot of categories. People refuse to be pinned down in lots of ways. And again, what are their pronouns? Have they been on hormones in the past or currently? Where'd they get those hormones? Did they get them through an MD? Did that MD know what they were doing? Sometimes there are a lot of well-meaning MDs who, like, they'll prescribe hormones with, just give me more. The patient said, that doesn't sound like enough milligrams. I need more milligrams. I said, do you even know how to spell milligram? Come on. So they'll get the physician to write a prescription for something that, well, that's what my friend is taking, but the physician is trying to do some good, keep someone in care, but sometimes they do the wrong thing. So how are they getting their hormones, and how do they get the hormones into their body? With youth, we ask a lot of specific questions. How old were they when they first felt some gender incongruence or dysphoria? When did they first express themselves? Where do they feel safe expressing themselves? Why don't they express themselves in certain places? What's up with their family? Does their family acknowledge them as a human being and who they are and how they identify themselves? That's really important. I was doing an intake the other day on a transgender 13 or 14-year-old. I had both parents. I sat down to talk with both parents. It's such a rare event. I had to tell them how thrilled I was that they were both there. Sometimes you get one parent. A lot of times there's no parent and they're a minor and you're kind of stuck with what you can and can't do in terms of hormonal treatment. A lot of this stuff in adolescent medicine is what we call HEADS assessment, general adolescent health questions. Where are they living? We just kind of tailor it a little bit to who we see in the clinic. So we have where they're living, who they live with, who do you talk to when you are stressed out or have a problem with trying to identify a supportive adult figure in their life, substance use questions, and so on. Mental health screen is a big deal. Were they ever physically abused? Were they ever sexually abused? Boy, the floodgates open on those questions like nobody ever asked me before. I got a lot to say here. Domestic violence, rape, suicidality, psychiatric hospitalization, and you know, a lot of these questions are how you establish your baseline rapport. The fact that you're asking them in a sort of supportive way makes a big deal in how people will engage in care. So, like I said, we follow guidelines. I used to look for anecdotal evidence, but boy, was I thrilled when I found WPATH. I don't know if Walter Bachning is on the Zoom, but Walter, you're a hero from your role with WPATH. Clinical guidelines from the Endocrine Society. There's actual evidence-based medicine. Not enough, but everything is very by the book, evidence-based medicine. We have evidence to back this up. We're not making this stuff up. You know, when you're doing treatment education, it's real simple. A lot of providers, they like say, well, I don't know if I give hormones to someone, like I don't know what I'm doing to their body. Say, do you prescribe birth control pills? Do you prescribe Depo-Provera for pregnancy prevention? That's what it does to the body. And so don't be so afraid of the side effects because you haven't been afraid of them in other situations. So that's really what you have to get comfortable with. Other than that, it's real simple. With somebody who's transitioning from male to female, you want to reduce the masculinizing effects of their endogenous testosterone as early as possible before they go through as much puberty, you know, as little puberty as possible. That's when you want to start. The younger, the better, because there's nothing more heartbreaking than telling a 6'2" transgender young woman, I can't shorten your shoulders. I can't make your shoulders smaller, and so on. Other things you can do, and just doing feminization in the shortest period of time. And then for female to male individuals, just the opposite. You want to reduce the feminizing effects of endogenous estrogen as early as possible, and so on. And hopefully I put in my Lupron slides somewhere in here. But the younger you can start someone on treatment, the better. If you can suppress their puberty, which is like suppressing puberty, it's illegal in Florida and Texas. Good for them. May they fall apart, or at least their political systems. So what do we have to deal with here in New York State in terms of consent and confidentiality? Well, you can treat someone's HIV if they're 16, but if they're 16, HIV positive and transgender, you can't really provide hormonal treatment. There are certain things you can get away with under the umbrella of contraception for transgender boys, for instance. You can't start them on testosterone, but they become extremely dysphoric from menstruation. You can't even use the word menstruation, period, around. You're bleeding. So give them Depo-Provera under the umbrella of of contraception, even if that's not really what you're using for, you can get away with that, they'll stop their periods. In most circumstances. So on the left are things that New York State allows us to have a minor give their own consent and confidentiality and so on. HIV care was added in 2017. Woohoo! We can give antiretrovirals to younger folks, and we can give PrEP to younger folks too. There are other things involved with like dealing with insurance and explanation of benefit letters and all that stuff. But the fact that we can do it makes a big difference. And parental consent is required for substance abuse treatment, mental health services, and gender affirming transgender care. Some of the things we have to deal with in clinic, you know, dealing with the IDs, discrepancies, it's ongoing, discrimination in the workplace. These are things that you just have to realize are going to be ongoing, and you want to see them decrease over time as you keep them in care and work with them in whatever ways you can. Physical exams. I have this conversation every day. Like, I'm a physician, I sometimes feel guilty because of the lack of physical exams that I do on these patients, but they don't even want to look at their own bodies, a lot of them. So the last thing they want to do is show it to someone else. So doing a physical exam becomes a conversation in advance that is important to have, and tell them, this is the body that you have, you better take care of it. But if I need to do an exam on you, I'm going to tell you about it, and you can walk in the door the next time you come in, we'll do it. We don't have to do it today, but it's important that you take care of the body that you have. I give this speech every day, and there was a young transgender man came to the clinic yesterday. Actually, he's been aged out into adult care, but he comes to our support group and told me he was just diagnosed with breast cancer. He's had top surgery. Take care of the body that you have. Still have annual breast exams, and at a certain age have mammograms. It's funny when I tell these kids, when you hit age 40, you have to start getting mammograms, and they look at me like 40. I'm not dead yet, you know. But start or prostate exams, age 50, those sorts of things. But I tell them that, like, these are things just remember as you get older, you know, got to take care of yourself and so on. Getting someone to pee in a cup for like urine, gonorrhea, chlamydia testing for the transgender girls, are all like taped and tucked, and it's like a big ordeal to go to the bathroom. Just be conscious of what you're asking. Like, when they're in the bathroom for 15 minutes, it's not because they're looking at Instagram in there. It's like a lot of preparation just to go pee, and to get yourself resituated afterwards. This is actually a slide we use with medical students. They want to know, when do we start hormones and so on? When do we use puberty blockers, which are referred to on here as GnRH agonists? The bottom line is, until they hit puberty, it's all about mental health. Once they hit puberty, you want to be able to suppress that puberty. And once they start getting to 15, 16 years older, you want to start assessing their readiness for being able to start on gender affirming hormone therapy. Whether or not you continue the puberty suppression becomes an individualized decision. And I don't know if everyone knows what Tanner staging is, but those are the adolescent medicine, pediatrics. Those are the stages of puberty. So Tanner 1 is prepubertal, and Tanner 2 is when you see that first pubic hair poking its way out, and say, oh, starting, let's get to work here. So there are benefits to puberty suppression. Just to keep in mind that puberty suppression is 100% reversible. And what puberty suppression does is it reduces dysphoria. It prevents unwanted secondary sexual characteristics, adult physical characteristics, and so on. And it gives you time to continue counseling and figure out when is the best time to start hormones. There will be a small proportion of young folks who might have some buyer's remorse. Like, I'm not sure I really want to do this. Give me more time, just keep me on puberty suppression. Or they say, I don't know what I was thinking, or maybe there was, an undertreated mental illness that was manifesting itself as gender identity issue and so on. So these are entirely reversible, all the effects of puberty suppression. All right, jumping ahead into some data. I know a lot of you folks are researchers, so I had to make sure to put in some data. So I did this, this was from, I think we did in 2022. At the time that we put all this data together just to see how many young folks we had and what did they look like demographically. You can see somewhat of an even split. It's a little bit weighted more towards the transgender women, and we have the non-binary folks assigned male at birth, assigned female at birth. That's what the MPX means there. You could see ages that folks on average enter care is probably like 18. They've already been through most of their puberty. So you got to do a lot of damage control around the effects of puberty. We are hitting the people of color that we want to be reaching in terms of who's coming in the door. You could see 58% Black, almost 25% Latinx, and so on. And so that's also a reflection of the neighborhood in which we operate, and also just like we're providing access to care to young folks who otherwise wouldn't know how to get it or don't have supportive families to get them into private doctors and so on. These are self-reports or diagnosis, like catch-all at the time of intake, and surprisingly enough, those that reported no mental health issues is the largest one. But the other numbers are a little disturbing, and those are the issues that are very labor intensive to address, that we have to address in the clinic. If you look at the lavender color, these are the percentages of folks who report being physically or sexually abused or being sexually assaulted. And the numbers are just frighteningly high. And those are things that not only address physical health, but their mental health later on. It's related to all the PTSD and so on, and translates into unhealthy relationships for many of them later on. A lot of the history of STIs, we see a lot of, I'll use a pejorative term, frequent flyers with particularly like with syphilis. Syphilis, I think it was just yesterday or the day before, it was on the front page of the New York Times. We treat a lot of syphilis in the clinic, but all the STIs, and so you have to constantly screen. We screen for STIs in these folks. We see them every 3 months. That's our goal. And we test them for STIs every 3 months, as well as testing hormone levels, viral load, and HIV status for those who are negative. For those who are HIV positive in that cohort, they tend to be very adherent to medication. Even the one person who was not virally suppressed in the cohort eventually got virally suppressed at a certain point because a surgeon wouldn't do her top surgery unless she was virally suppressed. So she had a period of viral suppression. But these are folks that are well connected to us, listen to our medical advice, and they're well connected to care. They come in, a lot of them come in every 2 weeks to get their injections in the clinic. So we have lots of opportunities to talk to them about treatment adherence. And now it's getting even easier with injectable antiretrovirals to keep folks virally suppressed. Claude, I know you've done a lot of work with perinatally infected youth. Like everybody likes to complain, oh, they don't take their medication. We're not having any more conversations with them. You're all getting injections. Just this month, I did a recount who we had in care right now. The numbers actually just this week went up by another 3. But you can see the breakdown, who we have in care in terms of HIV status, ethnicity, male versus female, gender nonconforming, and so on. And I'm constantly looking at the prep numbers, thinking we're not doing well enough of prep for the number of people that we have in care, 74 HIV negative individuals. Not everyone is at high risk for HIV. I think we're doing a good job with those that are at higher risk, especially, and it's not just the transgender young women. We have transgender guys who are also getting PrEP and so on. So it's important to keep them from becoming HIV positive. And when you're doing HIV treatment, how am I doing on time, by the way? Good. Again, being well-versed in doing both at the same time is essential to do and to keeping this population engaged in care. So your HIV ID providers that are well-versed in antiretrovirals need to learn about hormone regimens and so on. Be familiar with all the mental health aspects. Know all your HIV medications and your specific hormonal regimens. Are there interactions? Just be aware. Again, some of this is repetitive, but I'll go back to the role of stigma with HIV among transgender young women in particular. Like sometimes they don't want to even sit in the status neutral waiting room. I have an alternate waiting room. I'll wait somewhere else because I just don't want anybody seeing me come here. Just the outside chance they'll think I'm HIV positive. I don't know if Martez is out there in Zoom land, Martez Smith, who's a fellow here, but we had, I want to talk a little bit about house ball community because transgender women have a special status in the house ball community. You folks are shaking your head. Yes, not everyone knows what the house ball community is. Let's just call it alternative family structure by people who have been thrown out of their families and they just need family support. And so they join groups called houses that are not physical houses, although sometimes there may be a physical house involved, but houses of family. They're usually named after a fashion designer in some form or another. The House of Balenciaga. First one just comes to mind, and is largely an environment for Black gay men or Black MSM, and but transgender women are probably the second largest group that are in the house ball communities, and I think that they have a certain special status in there because of their looks, their glamour, and also their needs, and a lot of them take on very prominent roles in the house ball community. So a couple of years ago, this got funded April 2020, right at the moment the pandemic started. So yet another project that this one was a lot better than the Infinity project, which had a lot of disaster attached to it. This, we were successful, but had huge challenges. But basically what we wanted to do was take an intervention that was designed for Black gay men for HIV prevention and adapt it to a more HIV status neutral, gender inclusive group intervention. So, we came up with study aims to look at many men, many voices, which is referred to here as 3MV, and what were the key elements we needed to modify to make a new intervention, which we called Our Family, Our Voices, and we used an adapted model. I was like the only clinician in this group. I learned a lot, but when they all start talking to me about all kinds of researchy stuff, I say you have no idea what I go through every day just getting my patient documentation done. Stop telling me I gotta sit down and write this, that, and the other thing. I don't sit in front of a computer. I'm getting my hands dirty, or at least my gloves dirty all day long. Anyway, still working with those folks. It's a great group. This was you can see Martez's name at the bottom, inviting folks to a focus group. This was part of the first phase, was pulling folks together in focus groups to say, you've been through many men, many voices. What did you like about it? What did you not like about it? And rather than just talking to men, we had a focus group that was also for transgender women only. Our first aim, just to be in sync with the slides, was to what elements do we need to keep and what elements do we need to modify for our new intervention? And then will this function as a trial? Can we recruit an entire house as opposed to individuals? And what is the protective influence of house membership? Not just like 3MV kind of views everything from a pathology status. Here, we're looking at what are the protective elements of house membership. So could we send a house on a retreat, go through the whole intervention, and then follow them over 6 months? That's basic study design. And even in the control group, we offered them the intervention at the end of the 6 months. So in the focus groups, just to pull out some of these slides, what's underlined there is that everybody thinks that a trans woman is HIV positive. That is just something that like jumped out from the transgender focus group that we held. Something to keep in mind, again, stigma. And this one comes in stages. There's a little bit of ballroom activity going on with voguing. But in what ways are the houses protective, or for that matter, for those who are positive or negative? But this gets back to members of the community telling us that putting the information out there in a status neutral way, tell the HIV positive folks about PrEP. Tell the HIV negative folks about being virally suppressed, how everybody benefits from getting all that information and disseminating knowledge out into the community is really what folks felt was important. I got a quick case discussion. The details of the case are just to demonstrate some of the key points, just to break it down into an individualized case. Person came to me with known HIV infection. She came in right at the beginning of the pandemic. That was kind of fun. She hadn't been in care for several months, had fallen out of care, did not like the other provider, had a lot of alcohol and drug use history. She was adopted by her grandmother. Her mother became sick. She wasn't close with the mother. Was doing sex work. Up until the point she came in, rarely used condoms. Sex work, also in my clinic, we use the term survival sex. Pandemic had interrupted her transgender care, and one of her friends said, go to Dr. Jeff, he'll give you hormones. So she was sharing hormone pills with her friends, wants to get back on self-injection. Then she got hospitalized just prior to coming to me with pneumonia and so on. Again, I have a brand name up there. I apologize for that, but she was taking medication and was adherent to her HIV treatment, even though she didn't have a regular provider by the time she came in. When she came in, she had active syphilis, primary syphilis. Usually we pick that up on a blood test. Here she had a chancre on her penis. Gave her some estradiol injection equipment. And she wasn't sure where she was going to be living. She said, I'll just come in and pick my stuff up at the clinic. So it's another way to keep people engaged, have all their stuff delivered to us, and especially with young people. I want to confess to being paternalistic and wanting to make them feel like I'm going to be here for you, and I want to keep my eye on you and make sure you're okay. So come in and pick up your stuff here. Not everybody gets that treatment or needs that treatment, but we're definitely guilty of that. And just to see, there was one little lapse in viral load in September 2020 that had to do with an interruption in supply of her medication. You could see some hormone levels. These are just labs that we do. It almost doesn't matter what the results are. In clinic, it does. But just to see, we're tracking syphilis, estradiol levels, testosterone levels, and viral load. And that's it. So I'm gonna do, I'm gonna move this onto the other screen. That's what I was told I should do. Of course, I can't.
Let me do, yeah.
Move it up there, and then did you get that?
And then,
Maximize,
yeah.
see everybody. Disappeared. The tic-tac-toe board.
Well, we might not be able to see it.
Well, as many folks as we can.
Yeah, it might not show us. Tanya, I don't know if you want to go into gallery or we don't necessarily need to.
We can stop the share, right?
Oh, yeah, we can too. Yes.
And